the book. And just to let anyone know that's on the stream, we are monitoring chat as well. So if you have comments during the presentation that you'd like to share, we'll see anything that you might chat or just say hello. So let's start out with chapter 2 here, really diving in now to some content with Dr. van der Kolk's early career. And welcome, Simulations. I'm so glad that you could make it. I see you jumping towards us there. Dr. van der Kolk, in between his first and second year of college, so this is a very young Dr. van der Kolk, in his late teens or early 20s, he accepted a position in between his two first years of school at the Massachusetts Health Center in 1912. It's since been purchased and demolished sometime around like the 1980s or 1990s, and it's been an expansion in a large, a hospital campus. So it's now the Hale Building for Transformative Medicine. Much more modern looking building there in the lower right hand corner. But going back to 1912 and, into the 1960s, this was a mental health institute, much of the same vein where if you saw the movies One Flew the Cuckoo's Nest with Jack Nicholson, this was that kind of psych ward type of facility where they had, dormitories and common areas, and, you lived, with the patients and the doctors. And, I just found it interesting to point this out because I think it helps shape Dr. van der Kolk's experience because he actually worked, in one of these facilities where they had, those treatments that you may think of when you think of, 1950s health institutions. And welcome, Fuzz. I'm so glad you could make it too. So it's interesting, this idea of mental health asylums, kind of became popularized back in like the early 1900s where they built these giant facilities. This facility was up in Traverse City where my grandma lived very near Traverse City. So we drove past this as we would go up north, and our family loved to joke as we were sending somebody to the psych ward as we drove by. Somebody would always get picked. It's your turn to go in. But these places are absolutely massive. This is 300 square feet. So if you think of like the typical sort of four family member starter home is, anywhere from like 1,500 to 1,800 square foot. So, this is what, like 1,500 or would that be 150? Am I doing my math right? 150 family homes of space. And, you can see the absolute massive footprint that this building had down there in the drawing back in its heyday. Beautiful buildings, beautiful architecture because of the time period that they were built, but very questionable care as, many investigative reporters would start going into these facilities and reporting on what the treatments were like for the patients. And there you see kind of the dormitory with some of the staff there, back in this facility was operating. And let me just check. I make sure I didn't skip a slide there. Okay. So this chapter actually brings up, medicine and pharmacology in terms of treating mental health disorders, like schizophrenia and depression. And when I want to say back around the 1980s, there was this kind of movement of trying to shut down these large mental institutions, in the vein that this pharmacological solution was now like making it possible for people to re-enter society, where they were having trouble functioning so much that they were institutionalized. So from a period of about 1950 to 1996, these large institutional buildings that, like we saw in the last slide, started having their patients, discharged, and you went down from a population of about 500,000 to 100,000 in the 1990s. And it was very controversial, and you can see by the graphs there, that is the correlation between mental health patients and prison inmates. So you can see there's a bit of a jump there as patients were released to the public. Unfortunately, due to mental health issues, a lot of them ended up being convicted of some or another crime and, becoming an inmate. So, sociologically, it was really just an exchange from one institution to another. And with what we know now about the mental health institutions, I don't really know which one I would rather be in, to be honest. But I think what it underscores is that there really was not a solution, in the 1980s for a mental health crisis, and shutting down those institutions did not, in fact, address it. And but the change factors for this movement, were basically the accessibility to medications now as a treatment. Also government cost pressures. I remember here in Michigan, Governor Engler basically defunded the whole mental health institute state fund, and it shut most of them down in the 80s. I don't think there's any left operating. There's also public outcry for these institutions to be closed, because it was kind of felt that they really weren't helping after a lot of investigative reporting. So their legacy now is these kind of derelict buildings. So if you're into urban spelunking, there's lots of these abandoned asylums around the nation that have this kind of paint peeling off the walls look to them, and this old archaic and scary equipment still sitting there, and these skeletons of old tables and things. But for the most part, maybe a really good thing that these large institutions were shut down, and hopefully we can find much, much better individualized solutions through Dr. Vanderkolk's research. Another thing we learn in Chapter 2 is that Dr. Vanderkolk was part of the group that had input to what's called the DSM, gosh, I'm forgetting the acronym for it. Does anybody in attendance remember what DSM stands for?
Diagnostic and Statistical Manual.
There we go. See, we're surrounded by so many experts. I knew somebody would know. Thanks, Haya. Yeah, the Diagnostic and Statistical Manual.
Mental disorder.
It sounds so sterile, doesn't it? Gosh. But yeah, here they are, is the list of mental disorders that fall under what's called the Diagnostic Statistical Manual. It's kind of like this universally approved guide of how you can diagnose somebody with a mental disorder. It lists all the symptoms and scenarios that we know of for different disorders. So, when you do work with a professional, if you feel you have a mental disorder, they can help, with having studied this guide, kind of give you advice. And my two most favorite ones are, of course, the post-traumatic stress disorder, which we'll find out, which we found out in Chapter 1 became an official mental disorder. Before 1980, there was no such thing as post-traumatic stress, where you had considered to have a mental disorder because of some past event that's been difficult to to get past. And my second favorite one is just other. How fun is it to just fall into the classification of other? But yeah, Dr. van der Kolk has been recognized for his work and his work on the on that manual, and also he has been advocating for a new classification of PTSD, which is called complex PTSD. And this is kind of near and dear to my heart because, the official guide currently will classify PTSD as like an acute occurrence, like one thing happened and that like is where everything is stemming from. But what complex PTSD is kind of doses of traumatic events that sort of stack on top of each other and then like interact. So you have these varying triggers that are sort of creating a whole experience as opposed to like one thing that happened. So I really love the idea of complex PTSD because I think a lot of people fall into that category where you just grew up in family homes that maybe had like an emotionally neglectful set of values as a family. So nothing like specifically happened, but over time your nervous system gets cooked by just like the constant presence of this dysfunctional family side. And developmental trauma disorder, this is something Dr. van der Kolk feels should be studied, which is the effect of trauma on children in terms of their development. How does a traumatic experience, when you have, a child's mind, we're talking 3, 4, 5 years old now, how does trauma shape your experience, before you've gone through your teen and adult, development. So, another aspect of Dr. van der Kolk's current work, where he's still active in the field and trying to push these things. And of course, really breaks my heart to read about these experiments where, Dr. van der Kolk found out about the learned helplessness experiments where they utilized dogs to find information on behavioral aspects and, absolutely morally reprehensible. And I'm happy to say that these studies would be illegal by today's standards. And Dr. van der Kolk was really curious about the findings in these because he felt they also applied to traumatic disorders. And essentially, if you're not familiar with what this study was that a dog would be placed in a confinement system, much like you see there, where there's 2 electrified floors, and the side that they're sitting on, there would be like a light that would turn off, so there would be like an indicator that an electric shock was coming, and then they would jump to the other side to escape the shock. So what would happen is for some of these dogs, they would make both panels active, so they would jump from one shock into another shock. And for that group, that's where they learned about this concept of learned helplessness, because the dog would discontinue trying to escape and would just, unfortunately sit there and continue to get this mild shock. And what they further found out in the study is that they would open the cage door, or this confinement that they were in. They would open the door, and the dog would still just sit there and get shocked. So this coined the term learned helplessness, where you're in a situation that kind of defeats your nervous system to the point that you even lose the energy and the motivation to escape it, even when the escape is like just sitting right in front of you. So what happened is Dr. van der Kolk sought these people down, and what he was most curious about is he said, in the group where they physically removed the dog, that wouldn't leave the cage, they physically removed the dog from the shack. Those dogs learned, oh, I can escape, and they became like part of the group that would leave if the door was open. So he became very kind of laser focused on this idea that when you apply that to trauma, if your trauma is ongoing and it gets you into a state, you may be kind of resigned to stay in that traumatic space, without, completely losing the hope that anything can change. So what Dr. van der Kolk's theory was that treatments, like talk therapy and medications, perhaps they can be the metaphorical being yanked from the cage and learning that there's this outside feeling that's, in a different space, in a different head space, in a different body space, that you can then sort of begin this process of, getting yourself out of that traumatic state, whereas before you might just be resigned to kind of stay in that state. But the kind of the mechanics of entering learned helplessness are like, first the realization that the pain can't be escaped, and then falling into a depression. But here's where it gets really sinister, is that the pain and the depression actually lead to dysfunction. So now even if there is a pathway to escape, you are now, mentally or physically dysfunctional in order to take that path. So what happens is this kind of unwillingness or inability to escape. And I do think that this has a parallel to trauma, because trauma can reorganize like how your mind works with being hypervigilant, kind of make your mind focus on different stimulus, when you're evaluating threats with this hypervigilant, like, to give you an example, we can always use road rage, right? Like somebody cuts someone off and they might just slow down and be like, whatever. You cut another person off, they'll fly off the handle, right? Maybe that's because they're in this state of hypervigilance where that triggered their body to have this kind of violent response. So this concept of learned helplessness, I think, has huge parallels to healing from trauma. And another question here, and I just see a little bit of chat activity. Let me catch up on the chat here. So, we got Carl in the chat. Thanks for sending some notes. Great example of public perception, taking something positive and spinning it into a negative term. So many people today worried about the asylum seekers. Yeah, I'm glad you noticed that. Also, hello, just getting a quick taste for this week while I'm on break. Hope the rest of the event goes great. Yeah, I know you said you could kind of attend like every other week, so I'm really glad that you posted and you could check in. Thanks, Carl. So another, kind of finding or hypothesis that Dr. van der Kolk presents in Chapter 2 is this idea that you can develop an endurance or even an addiction to trauma. And he actually did a study on it where he invited combat veterans to go into an ice bath, which I don't know if you've ever experienced an ice bath, but you can also recreate this really easily in the kitchen, where if you want to just create like a pitcher of ice water and stick like your hand in it, it's actually painful. Like after 10 or 30 seconds, like it's like, ow, you're ready to pull your hand out. So you can imagine then like submerging your whole body into that into a bath of ice water. And what he did is, these were combat veterans, so he had two groups. One group, he had the movie Platoon playing, which is a very graphic war movie that, is kind of made for veterans to sort of honor like the true horror of what, being a Vietnam soldier was like. And the other was like some movie like Ferris Bueller's Day Off or something. And the combat veterans could stay in the ice bath longer if they were watching Platoon. And what Dr. Vanderkolk found was that the re-entry into that trauma state actually like improved their ability to endure things, which is another thing that's so sinister about trauma, is it elevates your ability to endure. So it sort of lessens your motivation to get out of it, because you're like, I got this, I've been through this before. I know what to do. My body will carry me. So in some cases, he, even postulated that it can become sort of an addiction. I don't know if addiction is the right word, but more like seeking familiarity. If you may know somebody in your life that like kind of goes in and out, a lot of us refer to it as like falling off the wagon, right? Like you have some difficulty in your life that you keep slipping back into. But you see sometimes they'll make a huge effort to kind of reorganize things and get, back on track, but then they'll sort of relapse. And that's an example of this kind of returning to that traumatic state. And part of it is what Dr. Vanderkolk realizes, is that like it feels so foreign to not be like immersed in your traumatic experiencing that you can sometimes go back to it and seek it because it just has that familiar territory. Like, you finally got the map again and you know how to navigate it. But as we know, like remaining in a traumatic experience, for life can be very painful. So I think it just underscores like how important it is to seek help if you do finally, have this revelation that I do carry some trauma. It's a great thing to set the intention to heal, because it's difficult to get. It's very pattern forming if you do suffer from PTSD. And this was hugely informative for me too. And I see we got a Desynchronize is checking in here from our Discord. Observed it in your own dog. It looks like I got my stream set up so the text kind of cuts off, but as the dog was a baby and got kennel trained, he stopped trying to get the door open even when it was unlatched. So I can just picture it. And then, and as a responsible, loving owner, you sort of addressed that. I love that. And a curtain. Okay, curtain. I love that solution too. And eventually he realized he could just go through the curtain. And now he loves playing with the curtain. Oh, I love dogs. The devil is less scary than uncertainty. Oh my gosh, that is like the best way to summarize that slide we just went through. And I just want to say how much I love pets in relationship to trauma too, because one of the things I learned from animals is like, they don't have a lot of the separation of body and mind that we do. So animals really have a closer connection to their body. So if their body is telling them fear or hungry, they're super honest about it. Like they don't have a reasoning center that can just be like, later, I got to work right now. Like if that dog's hungry, its whole demeanor is, I need to find food, and we have a way to like push that away and shut that down. So like our body can suffer because our mind decides something's more important. So if you're in the proximity of a pet, you can really absorb this kind of mindfulness from them. And they sort of are great at presence practice. And, every time like a dog like bumps you or gives you a boop with its snout or something, it's like, I feel like it's the dog just reminding you, like, the present moment is what's important. Like, let go of those worries. Are you hungry? Are you thirsty? Just simplify it. So, yeah, thanks for bringing a nice little dog anecdote into everything desynchronized. And yeah, so this was a really eye-opening part of the book for me when he introduced the topic of serotonin. Before I had read the book, I had no idea like about serotonin or what it does. But it's kind of a hormone that your body releases when things are like okay. You're if you're in a traumatic state, the parts of our brain that process trauma that really activate when we're triggered are also the parts that are responsible for releasing hormones into our body. So when we're in a trauma state, one thing your body does is it sort of dials down serotonin to pump things out like adrenaline, where you're needing to fight or flight. And he read a study about great apes and a study of serotonin levels. And what Dr. Vanderkolk found is that apes with higher serotonin levels tended to be leaders in their community. They tended to have a much more like esteem for themselves, and were able to navigate social situations. And lower serotonin levels in an ape like typically meant that they sort of stayed on the sidelines, or might allow other apes to prioritize themselves. And what's interesting in the experiment is they flipped the script and they lowered the serotonin in the apes that previously had high serotonin, and raised the serotonin in the apes that previously had low serotonin, and the dynamics of the troop flipped. So now the apes that had previously experienced this kind of low self-esteem like became leaders and built this like self-confidence that where it really manifested in their relationships. So it kind of proved that there is this serotonin to behavioral link. And what happened is they found the process where the body kind of reabsorbs serotonin. There's what are called these serotonin receptors. These are these little kind of funnels in our brain that sort of suck up the serotonin and reabsorb it like into the body so it can become materials for something else. What they found was that in animals and people that had PTSD, there were fewer of these serotonin receptors. So even if you're producing the serotonin, it's like your body doesn't quite like absorb it properly. And what they would do is they formed these drugs that would kind of plug if you see the little ball there, kind of like plugging the serotonin receptor, so that way the serotonin floated around in the body a little bit longer, so that it could be utilized. And that's basically what an SSRI is it's a drug that like blocks these little reuptake. It's called a reuptake inhibitor, which means that it inhibits the process of the serotonin being reabsorbed into the body, which means more serotonin is there for your body to utilize. Your levels of serotonin rise, and you get the benefits that are derived from serotonin. So a blind study in 1988 showed that these SSRIs showed significant improvement in traumatic patients that had PTSD. Unfortunately, there's still some mystery about combat veterans not responding to it in the same way. So out of respect to, what people experience in combat, our combat veterans, there really are differences in the traumatic experience that show up in different ways of treatment effectiveness. But yeah, really interesting that these SSRIs and trying to control levels of serotonin, like has this kind of mood and self-worth kind of implications. So yeah, what does that mean in terms of like the conclusions of this chapter? And if you take these concepts, so like learned helplessness and trauma endurance and drugs like Prozac, these SSRIs that we just learned about, if you're stuck in this traumatic life cycle, what it does is it drops your serotonin down. Also dopamine, which we haven't talked about yet, but I know it'll come up again. But all of these, hormones that we produce, which tell our body like everything's okay, there's nothing to worry about. If you have PTSD, your body can start, lowering the processing of those hormones and even the production of them. So I have this chart down here, and it's like in a period of years, and like I mean that literally, like this process doesn't happen like overnight. It takes years for the body to make these adjustments. It takes years of kind of being in this environment that's causing trauma. And if your serotonin kind of drops to this level that I have labeled as hypervigilance, which is when your body finally flicks the switch to just always scanning for, is something about to happen that's dangerous. Once your serotonin drops to a certain level and you get into that hypervigilant state, there's kind of like no way out, because, once you get to a certain threshold, PTSD and depression is kind of a threshold type of an experience. Like once you get deep enough, it's really hard to get back out on your own because your body changes. And that's where the learned helplessness kind of sets in, is you lose the motivation or even the ability to sort of get back above that hypervigilance threshold, and you can sort of get stuck. So the idea of treatments like SSRI as an example is that if you can boost your serotonin to the point where you can get back above that hypervigilance threshold, then you can start like recovering your body and your mind's ability to begin making adjustments and changes. We talked about how PTSD can inhibit your imagination, and how imagination is so important to changing, because you have to imagine, what your life would look like if you make a change. So yeah, the SSRI theory was that perhaps it can just boost people above that threshold and maybe kind of get, the metaphorical being yanked out of that cage that's shocking you, as a thought. And I kind of loved that theory. And let's see, a couple more comments from Desynchronized. Finding it tracks. Oh, yeah, thanks for the share here. I have functional neurological disorder and ADHD. And now they think linked to serotonin. Oh, wow. Thanks for, so on topic. I appreciate that you shared this. Also, I'm so sorry to hear that. I definitely identify with having some trauma in the past. And you're on an SSRI. Okay, that's good. You can speak with some experience on the topic. And, you're in a wheelchair and shutting down just a few months ago. I'm so sorry to hear it's that difficult. In addition to medical treatment, I was trained on cognitive behavioral therapy, and we used neuroplasticity to bypass the... that lead to... Yeah, we are going to get to that part, too, in the upcoming chapters about how, I don't know if it's still theoretical at this point, but it kind of tracks for me that, these trauma experiences in our body and how they can change our hormone levels, they can also lead to like other ailments like in the future, because, the body running on, if you think about something like serotonin, if your car's low on oil, and we continue to drive it for so many miles, it's eventually not good for the engine. And I think trauma can be the same way, where it can even lead to other ailments. So I wanted to disclose I'm in no way affiliated with, Pfizer or Philip Morris, any of these, big kind of corporate pharmaceutical. I'm not here to promote the idea of medication as a treatment. And Dr. Vanderkolk, I think, is really careful to point out some pros and cons too. And the pros we talked about to some degree, which is that you can potentially get some quick relief. Some of these medications, they can work in a matter of days or weeks to where you can really feel a sudden difference. Serotonin levels that are higher can improve mood, wellness, and motivation, which are important to kind of just general well-being, but also like making changes. There's also placebo effects. If you set an intention and motivate and try a medication, even sometimes just the attempt of trying something new can really invigorate the mind and the body to make changes and get better, like on its own, like independent of the drug. The cons are, it can displace other treatments. This is the philosophy of, get a prescription and go home, where a doctor, might not necessarily listen to exactly what happened, but they might just prescribe you something and expect, you're just going to be on this drug now. So, maybe talk therapy could have helped, but if the drug, it becomes the primary treatment, then you never find out. And Dr. Vanderkolk raises a really good question, which is if antidepressants are so effective, like why have hospitalizations not decreased for depression? Statistically, the same amount of people are still having struggles with depression. So if SSRIs are so effective, why hasn't it, made that number dramatically decrease? It can be ineffective in some groups, as we talked about, combat veterans maybe being a little bit resistant in pharmaceutical approaches. But, the biggest one here is probably the pharmaceutical industry itself. I mean, how many reports have we seen where, it's been disclosed that doctors are incentivized to prescribe one drug over another? There's billions of research and, government costs to producing a drug. So right out of the gate, they're trying to recoup, billions of dollars in capital investments. So those lead to a lot of shaky motivations, as, we all well know, happen. These create these kind of what's it called, conflict of interest situations, right, where you're putting the company like over the patient. Pave paradise and put up a parking lot. Dr. Vanderkolk's anecdote about how they deconstructed the basketball like gymnasium and they put cubicles up for people to manage like the prescription logistics. And they paved, or they took the pool out too in the mental health facility to make room for laboratories to produce these medications. And he said that those were places of social healing, like what we're doing right now. Like imagine somebody put up a bunch of VR cubicles in here and told us we could no longer meet. So, gosh, that's something I don't think we ever would have heard about if we weren't listening to somebody who kind of lived in the space. And it can be temporary. The SSRI boost of serotonin, you might need to stay on that, to continue to get the serotonin. So it can be, become a lifestyle instead of just a temporary treatment. And just a couple more comments here too. Desynchronized, I wanted to catch up with you that, you got into a pilot program? It hasn't been rolled out everywhere. They're using the same knowledge pool you're discussing here. Oh, I'm so happy to hear that. Yeah, these are very, the book is from like 2005, I think, but now that it's 2025, I think it's getting to the point where some of the concepts in this book are like being practiced. And yeah, modern prophets over people. You said a mouthful there. Thanks, Desynchronized, for the comments. And we have our first mention of this part of our brain called the amygdala. I don't know if that's a familiar term with everybody, but we're going to talk about it a lot in this book because the amygdala is almost solely responsible for if we feel there's a threat like in our presence or not. So if you're ever kind of walking through the house at night, with the night lights on because you're thirsty for a drink of water and you just hear the house kind of creak, that feeling that you get, like, what was that? You're alone, but what was that sound, right? Like, that's your amygdala. And the amygdala is part of what's called the limbic system, which are these four components: the hypothalamus, the amygdala, the thalamus, and the hippocampus. And they form this system that's kind of like, if you want to consider it like our primitive brain. In the 60s, they affectionately called it the lizard brain because it's sort of this de-evolved, like, run or fight. Like, it's that kind of simplistic. And as humans, what we have is, like, if we go back into our evolutionary lineage, like back in the day, we were mostly just our limbic system. Like, we didn't have this really big special reasoning center in our prefrontal cortex. The world was basically just danger or not danger. But as our prefrontal cortex and these more complex systems kind of grew into our bigger headspace, the limbic system is still there. So it was like, if you consider the limbic system like brain 1.0 and like our reasoning centers like brain 2.0, but like brain 2.0 operates on top of brain 1.0. So like, it's still, all of these systems are still functioning. So what happens is the amygdala can kind of pull your presence like away from your reasoning center when it gets overactive, and it starts just seeing everything as, something to be afraid of. And as you may know from experience, that can get really exhausting. And, we're going to talk about all these processes in more depth as we get going. And our inspirational quote from the day actually comes directly from the book, Dr. Van der Kolk himself. Our capacity to destroy one another is matched by our capacity to heal one another. So yeah, with that, I'd love to open the floor. We got our hand raise tool. I'm interested in hearing any and all comments. And also, I wanted to mention, if the hand raise tool feels like a little intimidating, we're a pretty good group here. So please, if there's just a pause, feel free to speak out and take the floor. But also no pressure. No pressure. We're not here to kind of institutionalize a sharing session. So if just the presentation was enough, that's also good. That's this event can be whatever we need it to be.